Vanakkam. When we talk about phalangeal fractures, we are talking about middle phalangeal and proximal phalangeal fractures, since we have already dealt with the management of fractures of the distal phalanx in a separate video. And such phalangeal fractures can be fractures of the base, which are quite complicated, can be fractures of the neck and shaft, which are quite straightforward as far as the management is concerned, or it could be fracture of the head or the condyles of the phalanges that look simple but can get quite complicated if not managed properly. So to understand the management of condylar fractures of the phalanges, we need to understand the anatomy of the condyles, that is the head of the phalanges, the attachments of the collateral ligaments, which are so important and play an important role in the stability of the fixation, and of course the movements or the biomechanics of the interphalangeal joint, either the proximal interphalangeal joint or the distal interphalangeal joint, which are so crucial to getting back function. This video deals with the management of condylar fractures, unicondylar fractures, bicondylar fractures, and even comminuted fractures. When we need to study about fractures of the phalanges of the fingers, we need to understand fractures of the head of the phalanx, that is the condylar fractures, fractures of the base of the phalanx, and fractures of the neck and shaft of the phalanx. In this video, we shall be concentrating on phalangeal condylar fractures or fractures of the head of the phalanges. And in this, we shall be learning about the anatomy, the dynamics of the collateral ligaments which are so closely associated with the head of the phalanges, classification of the phalangeal condylar fractures, the common features, the investigations needed, and of course the management of phalangeal condylar fractures. When we talk about phalangeal condylar fractures, we mean the head of both the middle phalanx and the proximal phalanx. They are quite similar in most of the features. Let us first consider the anatomy of the head of the phalanges. We have two elevations known as the condyles on the articular surface of the head. Lateral to these condyles is a portion of the head that is not covered by articular cartilage and is known as the lateral condylar ridge. Between the two condyles is a groove or notch known as the intercondylar groove. The articular surface extends more on the volar aspect than on the dorsal aspect. The articular surface on the base of the phalanx, which is distal to this phalanx, is much smaller, and this is because the flexion occurs not only with a hinged movement but also a translation. Now this joint, which is the interphalangeal joint, it could be the proximal interphalangeal joint or the distal interphalangeal joint, is covered on the volar aspect and on the dorsal aspects by a joint capsule, and on the volar aspect it is reinforced by the volar plate. On both the lateral aspects we have the proper collateral ligament that runs from the proximal phalanx to the middle phalanx or from the middle phalanx to the terminal phalanx. Just anterior to it is the accessory collateral ligament that runs from the bone to the volar plate. The proper collateral ligament of any joint runs from the proximal bone to the distal bone, whereas the accessory collateral ligament runs from the bone to a part of the capsule. The two condyles on the head of the phalanx are not parallel. They have an angle of divergence of about 10 degrees to 37 degrees. Within the joint is the synovial membrane, and the synovial fluid is important for the nutrition of the articular cartilage and secondarily for healing of any fracture that can occur. Movement is the most important function of these interphalangeal joints, of which the head of the phalanges forms an important part. The collateral ligaments, the finger position at time of injury, and direction of force influence both the fracture pattern and the direction of displacement. We shall now look at these collateral ligaments and their important role in the function of the interphalangeal joint. On both sides of the head of the phalanges, there is a flat area which gives attachment to the collateral ligaments, both the proper collateral ligament and the accessory collateral ligament. The vascular supply to the condyles is by a branch of the digital artery and vein that travels along over the surface of the collateral ligaments. So it is very important that care must be taken not to disrupt this blood supply or to strip small fragments of their soft tissue attachments, especially the attachments of the collateral ligaments. When the interphalangeal joint is extended, the proper collateral ligament is relaxed while the accessory collateral ligament is stretched. In flexion, the proper collateral ligament is stretched and the accessory collateral ligament is relaxed. There is another important dynamic event that occurs in flexion of the interphalangeal joint, especially the proximal interphalangeal joint. When the joint is flexed, the flexor tendon pulls on the palmar plate through the pulley. So a sort of suction develops that pulls the synovial fluid from the dorsal side into the palmar recess. But when the interphalangeal joint is extended, the flexor tendon and the accessory collateral ligaments press the palmar plate against the joint, and this pushes the synovial fluid from the palmar recess dorsally into the dorsal recess. So alternate flexion and extension bring about good circulation of the synovial fluid, hence giving nutrition to the articular cartilage and helping in healing of the fractures. To understand condylar fractures of the phalanges, we need to understand how they are classified. There are three categories according to the classification proposed by London in 1971, where type 1 consists of stable fractures without displacement, type 2 includes unicondylar and unstable fractures, and type 3 fractures are bicondylar or comminuted. The unicondylar fractures alone form a big chunk of these type of phalangeal condylar fractures. Hence, unicondylar fractures alone have been classified by Weiss and Hastings into four categories. Type 1 unicondylar fracture refers to the short oblique type, which is unstable. These fractures typically originate in the intercondylar groove or notch. Under Weiss and Hastings type 2, the unicondylar long oblique fracture is seen. This is also an unstable fracture. These long oblique fractures typically originate through one of the condyles splitting proximally towards the diaphyseal cortex on the side of the uninjured condyle. This can be clearly seen in this example. Type 3 fracture is a coronal fracture involving the dorsal part of the head of the phalanx. This is usually a stable fracture, but it may be associated with a dislocation. Type 4 is again a coronal fracture, but this time involving the volar aspect of the head of the phalanx. Two other types of fractures that occur in the head of the phalanx are the bicondylar fractures, which are again unstable, and the comminuted fractures, which are otherwise called triplane bicondylar fractures. When we consider the behavior of the condylar fractures of the proximal phalanx and the middle phalanx, there is a slight difference. Proximal phalanx condylar fractures are much more common and more prone for stiffness at the proximal interphalangeal joint, whereas middle phalanx condylar fractures have a slightly better prognosis as far as the range of motion is concerned. But usually these fractures have a residual mallet finger-like deformity. Now let us consider the features and salient points regarding these phalangeal condylar fractures. The oblique fractures, that is the type 1 and type 2, occur through tension or rotation force, which are transmitted via the collateral ligaments. But the coronal fractures, that is the type 3 and type 4, usually develop due to compression forces. Unicondylar fractures of the phalanges are often unstable because there is very minimal periosteal sleeve holding them together, and the forces seen at the joint are substantial, and the oblique nature of the fracture line is inherently unstable. The most common condyle fractures that occur in the hand are the condyles towards the midline of the hand, that is the middle finger axis. So the ulnar condyle in the index and thumb are more commonly involved, and the radial condyle in the ring and little finger are also commonly involved. The typical patient presenting with such a fracture is usually a young patient who has had an injury from a ball during a sports activity. Such injuries can present in 4 different scenarios. Scenario 1. The patient will be able to flex the finger after the injury, and the fracture line can be very subtle. But we need to remember here that even non-displaced fractures are prone to displacement. Scenario 2. The patient may present with an obvious joint subluxation both radiographically and clinically. Patients with this scenario tend to present quite early. Scenario 3. With any fracture displacement, a rotational deformity might have occurred, and this can be assessed by either looking end on at the digit to look for any rotation of the fingernail position, or evaluating with proximal interphalangeal joint flexion. And scenario 4, there may be a subtle joint depression leading to an angular deformity, and this can be best assessed by examining the fingers in full extension. So to remember easily, the 4 important assessments to be made in phalangeal condylar fractures are: assessment of the full range of active movements at the PIP joint, examination of the fingers in full extension, examination end-on view of the fingertips in full flexion, and a good X-ray evaluation. Almost similar clinical pattern can be noted in collateral ligament injury or volar plate avulsion, or in obvious PIP joint dislocation. A good X-ray, of course, will clinch the diagnosis. The important thing to remember is the management of phalangeal condylar fractures, which are prone for problems. If there has been no treatment provided, deformity or stiffness of the finger PIP joint may occur. If it has been treated conservatively, displacement of the fracture may lead to either early painful arthritic changes or rotational malalignment on full flexion, and if treated with surgery, stiffness and loss of range of movements may occur. Since the fracture pattern and configuration is going to decide on what the management is going to be, multiple views on X-ray are most important. Osteochondral fragments are often larger than they appear on X-ray because the articular cartilage is translucent. A CT may occasionally be helpful if the X-ray is not very clear. Before talking about the different types of management of phalangeal condylar fractures, we need to remember that even initially non-displaced fractures are inherently unstable. For reasons we have already seen, non-operative management warrants extremely close follow-up for any signs of displacement that can occur of the fracture. Having said that, we now come to the crux of the problem. Should we manage these fractures conservatively or with surgery? Conservative management consists of immobilizing the finger and the hand in a volar slab POP that keeps the metacarpophalangeal joints flexed and the interphalangeal joints completely extended. Weiss and Hastings in a study showed that 5 of 7 non-displaced fractures treated conservatively went on to displace and required surgery. But yet another study showed that undisplaced unicondylar phalangeal fractures showed satisfactory results in a 11-year follow-up, except for pain in cold weather. So we can safely conclude that the indications for conservative management are undisplaced or minimally displaced, that is less than 1 mm condylar fragment, of course with a good follow-up. Unicondylar fractures in children can also be treated conservatively since the capacity for remodeling is much better in children, whereas if there is angular deformity or joint subluxation, conservative management should not be undertaken. That brings us to understand that the indications for surgical management are displaced unicondylar fractures of the phalanges, and even in undisplaced fractures, percutaneous fixation should be considered first, and fracture subluxations must definitely undergo open reduction and fixation. Before we look into the techniques of fixation, let us summarize what we have learned so far. What we should do in minimally displaced or non-displaced phalangeal condylar fractures and displaced fractures, whether non-operative management, percutaneous fixation or open fixation is indicated. In minimally displaced or non-displaced fractures, non-operative management can be done provided the patient is willing for a good follow-up. In such cases where the patient may not be able to come for follow-up, a percutaneous fixation would be ideal. Open fixation is not very much indicated in such minimally displaced or non-displaced fractures, but it can be thought of when the facilities for percutaneous fixation are not available. On the other hand, if the condylar fracture is displaced, there is no role for non-operative management except perhaps in children, in whom a minimally displaced fracture can be managed conservatively. Percutaneous fixation can be done in such displaced fractures provided that we are able to achieve a good closed reduction. Open fixation in displaced condylar fractures is ideal if closed reduction is not possible. The goals of surgical management or open fixation are anatomical reduction of the articular surface, restoration of stability, minimizing soft tissue injury and early mobilization. One of the important points to remember when we are planning a surgical management for a condylar fracture is an access to a C-arm or a mini C-arm. This would help us both preoperatively, where a fluoroscopic examination under anesthesia provides a good sense of joint stability and fracture fragment orientation, and postoperatively also, where the fracture reduction, implant placement and fracture stability are effectively evaluated fluoroscopically. The condyles can be surgically approached between the central slip and the lateral band if there has been a lot of displacement and manipulation is needed, or by the mid-axial approach if minimal manipulation is required. The commonest methods of fixation are by using K-wires or lag screws. K-wires have the advantages that they are technically easy, there is minimal soft tissue damage, affordable cost and universal availability. But the obvious disadvantages of using K-wires for fixing condylar fractures is that there is less stable fixation, and these K-wires do not offer any compression of the fracture fragments. So, early mobilization cannot be done, and if improperly applied, the K-wire may actually separate the fragments, and finally, the projecting K-wire may irritate the skin. Lag screws can be used for fixation of displaced condylar fractures or palmar subluxation of the DIP joint and in open fractures. The only contraindication would be a grossly contaminated wound. The advantages of using lag screws for condyle fracture fixation are that these screws provide compression, a single screw may provide sufficient stability, K-wires and mini screws may be used in combination, and sometimes even two mini screws can be used in larger fracture fragments. Even with all these advantages, only an adequate recovery of the range of motion can be achieved, and we should be guarded when explaining the prognosis to the patient. Now let us see the technical aspects of fixation of unicondylar phalangeal fractures with lag screws. First, anatomical reduction is mandatory, otherwise the articular cartilage may be damaged, leading to painful degenerative joint disease or digital deformity. The first step in fixation is a good exposure and good irrigation with pulsed lavage of Ringer's lactate to remove clots. Careful handling of the bone segments is very important to avoid crushing the bones and causing comminution, and the vascularity of the fragments must be maintained by retaining the attachments of soft tissues, especially the collateral ligament. Next, the fracture must be reduced either by indirect reduction, where traction is applied and lateral pressure by the surgeon's thumb and index finger will reduce the fracture. This can be confirmed using image intensification. Direct reduction can be achieved by using a small pointed reduction forces and again confirmed using image intensification. For short oblique fractures, that is type 1, fixation with one lag screw or a percutaneous K-wire is recommended. If lag screws are not available, one or more K-wires can be used also. For large fragments, all the screws that we are going to use can be placed proximal to the collateral ligaments. The only point to remember is that these screws should not be placed through incomplete fissure fractures as they may cause comminution. For small fragments, the screws need to be placed within the joint cavity through the non-articular facet of the condyle distal to the collateral ligament, and this point can be approached by flexing the proximal interphalangeal joint. The screw length needs to be adequate for the screw just to penetrate the opposite cortex. We can prepare for drilling by flexing the PIP joint and retracting the collateral ligaments, or by extending the PIP joint and approaching between the proper collateral ligament and accessory collateral ligaments. As for all lag screw fixation, a gliding hole is made for a 1 mm screw perpendicular to the fracture plane with a 1 mm drill bit and a 0.8 mm drill bit to drill a thread hole in the opposite fragment. After the lag screw is inserted, we need to gently tighten to compress the fracture, and we also need to slightly enlarge the entrance to the screw hole to partially countersink the screw head. This countersinking in the diaphyseal bone is done for two reasons: to reduce the risk of soft tissue irritation and ensures maximal contact area with the bone to distribute the forces. And this countersinking should not be done in the metaphyseal region as the cortex is very thin. For large fragment fixation, a preliminary fixation can be done by inserting a K-wire and then a 1.5 mm drill bit for a 1.5 mm screw to form the gliding hole and 1.3 mm drill bit in the opposite fragment to form the thread hole. Preliminary fixation can also be done with the drill bit left inside. Then drilling is done for the proximal screw. The distal screw is inserted first, and then after inserting the proximal screw, alternate tightening is done so that both screws are tightened together. After the fixation, both manual checking and with image intensification needs to be done. Let us now consider bicondylar phalangeal fractures. This usually results from sports injuries due to axial load combined with lateral angulation of the finger. Bicondylar fractures are of three types: long T-shaped, short T-shaped, and lambda fracture, which is a combination of a long oblique fracture and a short oblique or transverse fracture. This shows a lambda bicondylar fracture of the proximal phalanx with a fracture of the middle phalanx. The location of the drill hole would be on the lateral intra-articular aspects of the condyle where the small ridge is present. We need to insert two screws, one from either side, by the technique that we have already discussed. After inserting the first lag screw, it is tightened to achieve interfragmentary compression, and then the second screw is inserted and tightened. Coronal unicondylar fractures may be associated with dislocations. If the PIP joint is dislocated dorsally, a coronal dorsal fracture is present, and if dislocated palmarly, a coronal palmar fracture is present. To reduce a dorsal dislocation, we need to apply traction to the finger with the PIP joint in partial flexion and exert dorsal pressure on the displaced condyle to reduce the dislocation. And if it is a palmar dislocation, we need to apply traction to the finger with PIP joint in extension and exert palmar pressure on the displaced condyle to reduce it. If it is a dorsal coronal fragment, part of the fracture line on the lateral aspect of the head is covered by the collateral ligament. In such situations, flexing the PIP joint will draw back the collateral ligaments and it can be further retracted with hook to expose the dorsal fragment for fixation with lag screw. In palmar fragments, the collateral ligament complex is torn or partially torn. The remnant can be retracted to reveal the palmar condylar fracture line for fixation. Drilling is done by the technique described earlier, and then after inserting the lag screw, careful tightening is done to achieve interfragmentary compression. For fixation of the dorsal fragment, fixation is from dorsal to palmar, and for fixation of the palmar fragment, fixation is from palmar to dorsal. The postoperative care after such fixation with lag screws would be to initiate active range of motion at about 5 to 7 days when the edema has subsided. We need to splint the PIP joint in full extension when not exercising, and the K wires, if they have been used, are removed at 3 to 4 weeks. I hope you enjoyed the video. I enjoyed making it. Please click on the shown links to see more about the distal phalangeal fractures and their management, and of course the management of metacarpal fractures. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.